Today, we'll report on news from the 2015 World Congress on Lung Cancer. All this and more starts right now on OncLive News Network. Hello and welcome. I'm Laura Jones. Last week, oncologists from around the world attended the 16th World Congress on Lung Cancer held in Denver, Colorado. In an oral presentation given by Dr. Nayar Rizvi from Columbia University Medical Center, dual checkpoint inhibition with the combination of nivolumab plus ipilimumab was both clinically active and had manageable toxicity when given as an upfront therapy in patients with advanced non-small cell lung cancer. In the study that enrolled 148 patients who received one of 4 dosing regimens, overall response rates ranged from 13% to 39%, with the highest seen in patients who received the schedule of nivolumab at 3 mg per kilogram every 2 weeks and ipilimumab at 1 mg per kilogram every 12 weeks. Median progression-free survival ranged from 4.9 months to 10.6 months, the longest being for the group receiving each drug at a dose of 1 mg per kilogram every 3 weeks. Clinical activity was observed regardless of tumor PD-L1 expression, said Dr. Rizvi. We have preliminary evidence of greater activity in tumors that have 1% or greater PD-L1 expression. The median disease control rate was not reached in any arm, regardless of the PD-L1 expression. The safety profile of the immunotherapy combination was consistent with that of previous studies, and discontinuation because of adverse events was similar to rates observed with nivolumab alone. Next, new Phase 2 data for osimertinib, previously known as AZD9291, were also presented at the meeting. The third-generation TKI was associated with a 71% objective response rate in patients with EGFR T790M mutant non-small cell lung cancer following resistance to frontline anti-EGFR therapy. After a median of almost 7 months, the median progression-free survival duration was 8.6 months. A high objective response rate and promising progression-free survival with AZD9291 was observed across lines of therapy, said lead investigator Tetsuya Mitsudomi. The frequency of treatment-related grade 3 or higher adverse events was low, and only 7 patients discontinued AZD9291 due to treatment-related adverse events. Dr. Corey Langer from the University of Pennsylvania Abramson Cancer Center had this to say about third-generation EGFR TKIs in NSCLC.
Both rosimertinib, also known as CO1686, and the AstraZeneca compound AZD9291 have shown tremendous activity in this area with response rates of 45 to 60%, often quite durable, in some cases more durable than the original response to first-line TKIs. And again, there are several other experimental agents that are being investigated that seem to hold similar promise. And of course, the next step is to compare these agents in the first-line setting to the established first-generation TKIs.
Preliminary data were also presented for osimertinib in the upfront setting of EGFR mutant non-small cell lung cancer. In the study presented by Suresh Ramalingam, the 1-year PFS rate was 72% and overall response rate was 75% among the 60 patients enrolled in the Phase 1 trial. The encouraging findings were the basis for a new drug application, osimertinib, which was submitted earlier this year to the FDA and granted priority review. A final decision is expected during the first quarter of 2016. In other lung cancer news, the second-generation ALK inhibitor, alectinib, has also received priority review designation by the FDA for use in patients with ALK-positive advanced non-small cell lung cancer. The indication for alectinib would be for after progression or intolerance on crizotinib. Alectinib was associated with a 50% response rate in 122 patients with crizotinib-resistant tumors, including 60% who had CNS disease, and most of whom had already been treated with chemotherapy. Median PFS in this population was 9 months. The decision date by the FDA is expected in March 2016. Another drug, ixazomib, the novel oral proteasome inhibitor, has also received priority review designation from the FDA, this time for patients with relapsed or refractory multiple myeloma and in combination with lenalidomide and dexamethasone. The application for ixazomib was based on findings from the 722-patient Phase 3 trial in which the oral triplet therapy improved progression-free survival compared with Lindex alone, making ixazomib the first proteasome inhibitor to demonstrate efficacy in a Phase 3 trial. The FDA decision date for ixazomib is set for March 2016. A European approval decision for ixazomib is expected early next year. Lastly, AbbVie has submitted a supplemental new drug application for use of ibrutinib as initial treatment for patients with chronic lymphocytic leukemia who are older than 65. The Phase 3 data, which have yet to be released, showed ibrutinib in combination with chlorambucil improved overall survival, progression-free survival, and response rate compared with chlorambucil alone. Before we go, recently, OncLive filmed a panel discussion focusing on lung cancer data presented at this year's ASCO meeting. The video features a group of world experts on lung cancer who discuss how to apply the latest data to your practice. To view this peer exchange, please go to the link on your screen. And that'll do it for this week. Thanks so much for watching OncLive News Network. I'm Laura Jones. We'll see you next time.